Hello everyone, welcome to Voluson and the Expert webinar, which were organized by GE Healthcare. Thank you for finding time and visiting us today. My name is Tham, Application Specialist at GE Healthcare in Vietnam. So just a little bit housekeeping before we get started. To keep the quality of sound functional, please mute yourself during the lectures. And if you have any question during the lectures, please type them into the question box and click send. We will also have time for questions after the presentations. And if you want to know more about Voluson, you can scan the QR code at below. Thank you. So today we are presenting a systematic approach to the differential diagnosis of the complication monochronic twins pregnancy presented by Dr. Nguyen Ha. So she is a certified OB and GYN sonologist doctor. She has worked in the prenatal screening and diagnostic field in the largest maternity hospital of Vietnam for over 25 years. She has been officially elected to be the ISUC ambassador in Asia. It is an extraordinary recognition from ISUC for the consistent effort of Dr. Nguyen in organizing the healthcare system, training and developing the ultrasound in OB/GYN field in Vietnam during the last 25 years, and also her exceptional contribution to ISUC activity during the time. So please join us and welcome Dr. Nguyen. Over to you, Dr. Nguyen.
Good evening, everybody. I'm Dr. Nguyen Ha from Vietnam. First of all, I would like to pay my gratitude to GE who gave me the opportunity to deliver presentation today. My topic today is about a systematic approach to the diagnosis and management the complication of monochorionic pregnancy. Prevalence of teen pregnancy is about 1 in 250. Diagnosticity refers to the time of conception. 2/3 of all teens are dizygote and 1/3 of all teens are monozygous. Chorionicity denotes the time of placentation. 2/3 of monozygous are monochorionic and nearly almost monochorionic twins are monochorionic diamniotic twins. And we know that the chorionicity rather than the zygosity determine the outcome of teen pregnancy. Monochorionic teen pregnancy are at increased risk of adverse outcome, most because of the vascular anastomosis that connect the two fetal circulation systems. The shared circulation is responsible for some unique complications in monochorionic teens such as TTTS, TAP, or TRAP. And the second pathogenesis of monochorionic twins is an equal division of the shared placenta. This appears to be the most important determinant of discordant growth in the monochorionic twins. Placental vascular anastomosis can be of three types. Arterial, veno-venous anastomosis can protect against the development of TAP or TTS because bidirectional nature allows for the intestine equilibration of the blood volume, while arteriovenous with the unidirectional nature can create a transfusion imbalance leading to the severe complication like TTS or TAP. Ultrasound plays a key role in screening, diagnosis, and management the complication of monochorionic twin pregnancy. We should follow the practice guideline about the roles of ultrasound in twin pregnancy issued by ISUC. And we know a very important role of the 12-week scan is to determine the chorionicity and amnionicity. And most of you already know with the lambda sign is a dichorionic diamniotic twin, and with the T sign is a monochorionic and diamniotic twin. And this is the ISUC recommendation about time, frequency, and content of the ultrasound assessment for monochorionic twin. And you can see the patient is scanned every 2 weeks from 16 weeks till the end of pregnancy. And now we move to the diagnosis and management the complications that are specific to monochorionic pregnancy. Twin transfusion syndrome is the most severe complication in monochorionic pregnancy. It occurs about 1 in 10 of monochorionic and from 16 weeks to 26 weeks of pregnancy. Twin transfusion syndrome occurs if there is imbalanced blood flow through relative large placenta anastomosis, and the consequence is the donor twin is hypovolemia, polyuria, and the recipient twin is hypervolemia and polyuria. The diagnosis of twin transfusion syndrome is based on the presence of one twin with the polyhydramnios and the other twin with the oligohydramnios. Oligohydramnios is defined as the deepest vertical pockets under or equal to cm, and because the amniotic fluid increases with gestation, so polyhydramnios is defined as the deepest vertical pockets above 6 cm before 16 weeks, deepest vertical pockets above 8 cm before 20 weeks, and deepest vertical pockets above 10 cm after 20 weeks. Once the diagnosis of TTS is established, the severity of the condition may be assessed using the quinterol staging system. Stage 1 if the bladder of the donor twin is visible. Stage 2 if the bladder of the donor twin is non-visible. Stage 3 if there is critical abnormal Doppler in the donor twin, like the absence or reverse and diastolic velocity in the umbilical artery, absent or reverse flow in the distal venosus, or pulsative flow in the umbilical vein. Stage 4 if the recipient is hydrops, and stage 5 demise of either twin. Remember, TTS is not a homogeneous disorder. It may coexist with selective fetal growth restriction and or with TAP. In the study by Grun and Tollner, 60% of TTS associated with selective fetal growth restriction, and TAP detected in 50% of TTS twins prior to laser surgery. How about the management of twin transfusion syndrome? We know that if untreated, the perinatal loss rate of TTS may up to 70 to 90%. Until now, fetoscopic laser coagulation of the vascular anastomosis is the optimal treatment for TTS. And you can see here in a very large study, including 1,020 pregnancies with TTS by D and AO, they report the overall survival rate for both fetus is about 63%, and the overall survival rate for at least one fetus up to 86.7%. When twin transfusion syndrome is indicated for laser surgery. Symptomatic TTS stage 1, TTS stage 2, TTS stage 3, and TTS stage 4. How about the asymptomatic TTS stage 1? In a multi-centric randomized by Stineman in 2021 in 9 fetal medicine centers in Europe and US, asymptomatic women at TTS stage 1 from 16 to 26 weeks with a cervix above 15 mm were randomized between expectant management and immediate laser. The outcome was the survival at 6 months with rather severe neurologic morbidity, and you can see there were no difference in the outcome between the expectant and laser treatment. So they include, it is unlikely that the early fetal surgery is of benefit for stage 1 twin transfusion syndrome in asymptomatic pregnant women with a long cervix. And now we move to another complication of monochorionic pregnancy is selective fetal growth restriction. It occurs in about 12 to 25% of monochorionic. with a high rate of fetal demise and long-term neurological impairment. And in contrast to TTTS, very little is known about the optimal management and outcome in selective fetal growth restriction. The pathogenesis of selective fetal growth restriction is comprised of unequal placenta sharing and blood flow interchange through placenta anastomosis. So the diagnosis is based on a large intertwined growth discrepancy. As in a consensus definition and essential reporting parameter of selective fetal growth restriction in twin pregnancy, for solitary parameter, we need only one fetus had the estimated fetal weight under 10%. For the contributory parameter, we need at least 2 or 4. Estimated fetal weight under 10%, abdominal circumstance under 10%, discordance between two fetus above 25%, and the PI umbilical artery of the smaller twin is above 95%. Grotacode classifies selective fetal growth restriction into 3 types depending on the pattern of the end diastolic flow in the umbilical artery Doppler. Type 1, if the end diastolic flow is positive. Type 2, if the end diastolic flow absent or reversed. And type 3, if the intermittent, the absent and then present and then absent or reverse of end diastolic flow in the umbilical artery. In contrast to TTTS, the optimal management for selective fetal growth restriction remains unclear. More studies are required to determine how and when the pregnancy should be treated antenatally. And you remember that our goal of treatment is not only chance of survival, but also disease-free survival baby. It means the baby no cerebral injury and long-term neurodevelopment impairment. A difficult decision in management selective fetal growth restriction is when to induce delivery. It is a balance between prematurity and dismise. If we deliver at too early age, this may lead to complications associated with severe prematurity, including neonatal mortality and cerebral injury, while delivering this baby too late may also be associated with an increased risk of single or double fetal mortality and also cerebral injury in case of single fetal death. So the management decisions in selective fetal growth restriction are currently not based on evidence, rely primarily on expert opinion, and vary greatly between the centers. In a last study by Cook about the outcome of monochorionic with selective fetal growth restriction at 16 weeks, 20 weeks, and 30 weeks, according to new Denver consensus definition, they reported the prevalence of selective fetal growth restriction up to 26%. The early onset occurred in 73% and majority is type 1. The overall survival rate about 88%, with 82% is survival for both twins. Subsequent developing type in 3% and TTTS in 10%. So they conclude patients can be informed that the selective fetal growth restriction had good outcome. The survival rate above 90% in the absence of TTTS, abnormal umbilical artery flow, type 2 or type 3, and majority anomaly. How about the prognosis of early and late onset selective fetal growth restriction? Early onset is defined if occur before or at 24 weeks, and late onset if occur after 24 weeks. And in the study by Kuala, you can see the prevalence of early onset or late onset nearly the same, 5% and 4%. However, early onset selective fetal growth restriction associated the worst perinatal outcome. And you can see the incidence of type 2 and type 3 in early selective in 19.2% compared with the late onset only 5.6%. And the superimpose of TTTS is more common, 26% in early onset compared with only 5.6% in late onset. We know that unequal cell placenta is the main reason of selective fetal growth restriction. How can we recognize an equal cell placenta in a monochorionic twin? We can look for the cord insertion. And you can see in a study by Kuala, the incidence of birth weight discordance of 25% or more were significantly higher in pregnancy with filamentous or marginal cord insertion compared to those with normal cord insertion. So they conclude sonographic delineation of placenta cord insertion should be valued in antenatal stratification of teen pregnancy. And now we move to another complication of monochorionic twin is twin anaemia polycythaemia sequence. Twin anaemia polycythaemia sequence can occur spontaneous in 5% of monochorionic twin and up to 16% of cases after laser treatment for TTTS. It can develop across the entire second and third trimester. So the time of onset of spontaneous TAP may be from 15 to 35 weeks. And in case post-laser treatment, TAP usually occur within 1 month. And remember, TAP may coexist with TTTS and selective fetal growth restriction. And TAP in monochorionic monoamniotic or in dichorionic diamniotic also reported. Why TAP occurs is proposed by slow and chronic unbalanced fetal-fetal transfusion through minuscule placenta anastomosis under 1 mm, and this leading to anemia in the donor and polycythemia in the recipient without sign of TTTS. And the mechanism thus prevents TAP donor to develop oligohydramnios and TAP recipient to develop polyhydramnios not clearly understood. The hypothesis is that slow transfusion allows more time for a hemodynamic compensatory mechanism to take place in TAP. As TAP is established, we need to diagnose stage 4 management. Stage 1, if MCA-PSV of the donor above 1.5 mol and the recipient under 1 mol, or the delta MCA-PSV above 0.5 mol. Stage 2, if the MCA-PSV of the donor above 1.7 mol and the recipient under 0.8 mol, or the delta MCA-PSV above 0.7 mol. Stage 3, if the stage 1, stage 2 combined with the cardiac compromise of the donor. Stage 4, if the donor is hydro. And stage 5, if the intrauterine demise of one or both fetus preceded by TAP. In a recent consensus, diagnostic criteria and monitoring of twin anemia polycythemia sequence then via procedure by Professor Kalin, we had 2 criteria. First, MCA-PSV in the donor twin above 1.5 mol and in the recipient under 0.8 mol, or MCA-PSV discordant above 1 mol. Although MCA-PSV discordant is the cornerstone of the diagnosis of TAP, additional ultrasound marker associated with anemia and polycythemia have also been reported, like sterile sky liver of recipient twin, is caused by the hyperechogenic congestic proton venue and diminished liver parenchyma. Another additional ultrasound finding is dichotomous placenta. The placenta of the donor is enlarged and hyperechogenic compared with the recipient. The placenta is flattened and hypoechogenic. In a recent study by Tollner, majority of TAP twins presented with at least one marker, like dichotomy in 44%, steatocystine liver in 66%, and cardiomegaly in 70%. And the presence of the marker might indicate a poor prognosis is unclear. We need more future research. How about the management for TAP? There is no consensus on the best treatment for TAP. With the expectant management of preterm delivery, the baby has no risk of intrauterine treatment. TAP can resolve spontaneously, or we can treat anemia and polycythemia in the neonatal intensive care. Intrauterine blood transfusion may be indicated in case of severe anemia. For laser surgery, technical problem because the absence of polycythaemia and selective fetal size can be indicated in the case of severe early onset. And now we move to the last complication of monochorionic twin. Is the twin reverse arterial perfusion. TRAP sequence is a rare condition of monochorionic twin, about only 1%, and two criteria be necessary for the development of a TRAP. First, the presence of arterial anastomosis and an intrauterine demise of one of monochorionic twin, allowing for the reverse of blood flow. So whenever a single intrauterine demise of the monochorionic twin diagnosed in the first trimester, TRAP sequence should be kept in mind. The perfused twin is supplied by the oxygenated, resulting deficient in development of the head, the heart, upper line, and the pump twin may develop high output cardiac failure, high growth, polycythemia, and consequent premature delivery, and the mortality reported up to 50 to 70% of pump twin. A cardiac fetus had a specific finding on ultrasound, subcutaneous edema, irregular cardiac activity is made from the rudimentary heart beating or a retrograde pulsation from the pumpkin twin. The head, the upper body, and the upper extremity are poorly developed, while the lower body and the lower extremity are usually less anomaly, and the reverse flow in the umbilical cord confirm the diagnosis. The acardious acephalus is the most common type of the TRAP, about 60 to 70%, and these twins do not develop a head but may have an undeveloped skull base. Acardious ancest is the most developed form, about 10% of TRAP. This form has arms, legs, and a partially developed of head with the brain tissue and facial structure. For management of TRAP sequence, the size of the acardiac twin play an important role in the pathogenesis of complication in the pump twin. So we need to calculate the weight of the acardiac twin. Acardiac anomaly are also divided into two types. Type 1, small or medium-sized acardiac twin, when the abdominal circumference ratio under 50%, and type 2 is the large acardiac twin, when the abdominal circumstance ratio is above 50%. The main goal of the management of TAP is to preserve the survival of the pumpkin reaching the term of delivery. So optimal timing of intervention is still to be clarified, and technique of choice, laser coagulation and radiofrequency ablation of the interfetal vessel are preferred approach. And the last I would like to mention is the single fetal death. What happens if a fetal death? Circulating volume will be from the survivor to the destined. The survivor will be hypotension, will be hypoperfusion of the brain and other organs. The brain will be damaged, and finally the fetal may be dead. Monochorionic twin with a single fetal death must be managed in a tertiary level center, including detailed scan Doppler, fetal brain 4 to 6 weeks after later, and delivery at 34 to 36 weeks. Remember, an organ delivery may be too late to prevent long-term morbidity, so if preterm, prolonging the pregnancy for the benefits of the surviving twin. In a study by Markey about the prognosis of the co-twin following spontaneous single intrauterine fetal death in twin pregnancy, the prevalence about 6% of twin pregnancy, and preterm birth up to nearly 60%, and the abnormal antenatal brain imaging report in up to 20%. And I would like to share with you an interesting case. Acardiac triplets is the acardiac is a live fetus, and this is another demise fetus. And you can see the survival later had the damage of the brain with the absence of the corpus callosum and the hydrocephalus, and damage of the brain tissue can confirm with the MRIs. And the key home message of my talk today: at 12 scan, we must determine this is a monochorionic twin. And then for 90 ultrasound examination, it means that every 2 weeks we have to do ultrasound to assess the biometry, amniotic fluid volume, Doppler, including umbilical artery and PSV-MCA. If one baby with the polyhydramnios and one with oligohydramnios, it may be a TTS. If one twin and the estimated fetal weight under 10% and the estimated fetal weight discordant above 25%, is a selective fetal restriction. And if the delta mom of the PSV-MCA above 1, is a TAP. And remember, TTTS may combine with the selective fetal restriction or TAP, and TTTS also combined with TAP. Thank you for your attention.
So thank you, Dr. Nguyen, for giving us the wonderful lectures. So we will go ahead and take some time for question now. So just a reminder that you still can submit question through the question box. So the first question is, please describe Doppler finding in donor and recipient fetus.
Okay, let me share screen.
Yeah, Dr. Nguyen, you can share screen now.
So the first question, you asked me about the Doppler finding in the donor and recipient of the twin transfusion syndrome. So for the TTTS syndrome, we diagnose based on the discordance in the hydramnios, one with the oligohydramnios and one with the polyhydramnios. And when you diagnose the TTTS, the next step, you must diagnose the stage, because it will let you can manage how to manage the TTTS and predict the outcome. And for the Doppler, you need to do the Doppler of umbilical. And you remember for a twin, you do the position to do the umbilical artery. You need to do at the position that the umbilical artery insert to the body of the baby and bilateral of the bladder. So you sure it be the umbilical artery of the twin that you want to do. You don't miss with the other. If you choose a free cord artery, you have to choose at the bladder position to do the Doppler. And you remember for the TTTS or a monochorionic, every 2 weeks, we have to do the umbilical artery assessment Doppler. And it depends on the Doppler of the umbilical artery. If you can see if the baby, the donor, know the positive, the diastolic flow positive, it means the type 1 or type 2. And if the absent or reverse, it is the stage 3, and prognosis may be not good at the stage 2 or stage 1. So it depends on the umbilical artery. Is the end diastolic of the artery is positive or absent or reverse, we can diagnose the stage. Yes, and this is for the donors, donor team.
Thanks you, Dr. Wing. Yeah. So the next question is, how can we diagnose selective fetal growth restrictions in twin transfusion syndrome?
Okay, and another good question. And you know that for in the monochorionic, this is very common. We make the confuse between the selective fetal growth restriction and TTTS, and the important because both complication TTTS or selective fetal growth restriction, you will see one fetus smaller, oligohydramnios in the smaller and abdomen of Doppler. But the different important key to make the different diagnosis, because TTS is you look for the amniotic of the bigger, it means the normal baby, is normal or polyhydramnios. If polyhydramnios, it means TTTS, and if the bigger twin, the normal twin, had the amniotic fluid normal, it means the selective fetal growth restriction. So first you must clarify between the TTTS and selective fetal growth restriction, because two complications may be misdiagnosed together. And so when you do the selective fetal growth restriction, you can, based on the consensus diagnosis of the DELPHI in the consensus in 2019. And if one fetus, it means the smaller, have the fetal weight, estimated fetal weight under the 3%, it means the very small. You don't need the discordant or the abnormal of Doppler. You do the selective fetal growth restriction. And if the smaller baby, the estimated fetal weight not too small, it means from the 3% to 10%. It's not too small. You need another parameter. Another parameter may be the discordance between two fetus above 25%, or the abnormal of, it means the PI of umbilical artery of the smaller twin above the percentile 95. So it means, so you can do the diagnosis. It depends on the too small is very easy. No need to see the other factor like the Doppler or the discordant. But if not too small, just 3 to 10%, we need to do combined with abnormal on Doppler or the discordant of two fetus. Thank you.
Thank you, Dr. Nguyen. The next question is, what color Doppler finding in donor of twin transfusion syndrome is important?
So for the TTTS, if you diagnose the STEC just based on the abnormal or umbilical artery, but for the prognosis, you can do the other Doppler of the ductal venocyte or the Doppler of the umbilical vein. And when you see the abnormal of ductal venocyte or the pull, the abnormal on the vein, normally we don't see the pull, but when you see it means that the STEC works and predict the worst outcome, because the baby had a very severe situation and the heart may be failure. So maybe the treatment, maybe the successful treatment may be not good as compared with the earliest the other STEC.
Thank you, Dr. Nguyen. The next question is, what is the normal umbilical Doppler in selective fetal growth restriction? Thank you, doctor.
So the Doppler of the Doppler, I also say the answer for the Doppler, the abnormal Doppler on the selective fetal growth restriction, you do the you do on the only the umbilical artery, and it depends on the let me show you because the strata code define 3 types, and the study show that if the type 1 is a good prognosis, it means the end diastolic flow positive. It means the good prognosis and the successful treatment very high. But when the donor tin where had the absent or revert, it's the type 2 is not good compared with the type 2. And between the type 2 and type 3 is mean that the end diastolic intermittent positive, then absent, and then revert. It mean it may be that it's either it may be the early stage of the type 2, and the prognosis of type 3 is not good as type 1, but type 3 may be better than type 1. Yes, so compare studies show that if we compare the type 2 and type 3, the type 3 may be better than the type 1, type 2, but the type 3 is not it's not good. The prognosis, the successful of the treatment TTTS, the laser treatment is not had the high successful like the type 1.
Thank you, Dr. Nguyen. So the last question is, when should monochorionic twins be delivered?
Oh, very, it's a very complex question. You know that it depends on the baby had which complication. For the TTTS on the selective fetal growth restriction, it depends for the TTS when you had the baby grow is not with the good outcome get better and you can delivery, and when they had the complication with the severe TTTS type 3 or type 4, or for the selective fetal growth restriction, when the smaller, too small, and had the risk of the fetal death, and we may lose the other fetal. So it depends on which complication of the monochorionic, and for the treatment and experiment of TTTS is clearly for the management of TTTS complication, because the laser treatment had a better outcome and the time for the delivery. But for the other complication like selective fetal growth restriction or TAP or TRAP, you can see here the optimal management remain unclear for even the selective fetal growth restriction or for TAP. It has many different management, and the time to delivery. So it's really a complex question for the answer, but we have to balance between the premature. If you get the baby out, baby had the complication for the premature of fetal brain. If you continue to keep the baby in the uterus, one fetus maybe die. And you know, for a monochorionic, one fetus died, the second had the risk of the die because the balance, the connection anastomosis between the two teeth in the placenta. So when a fetus die, it may collapse, and the blood from the survivor will move to the demise, and the liver, the survivor will be hypotension, will be lost blood, and maybe die in just 24 hours. So very, very risk for the survivor and for the decision. I think this is to deliver, and for the management, really very important. The baby must have to manage in a territory with the experienced prenatal diagnosis doctor. Yes, so it's a really complex and difficult to make the decision.
So thank you, Dr. Nguyen. So it's look like we cover all the questions. So Dr. Nguyen, is there anything else you want to cover before wrap up?
Yes, so you know that's for the monochorionic. You see, for a monochorionic, the complication, the TTTS is the most common, but we can diagnose it very good, and for the outcome, the very clearly evident for the treatment, laser treatment. But for the other complications like selective fetal restriction or TAP or TRES, also sometimes we miss, and for the management also difficult decision. So for the ultrasound, for the prenatal diagnosis doctor, I think from the 12 weeks we must we have to determine very exactly at the 12-week scan to recognize, to identify the monochorionic diamnitin, and then from a 16 week we have to follow up to scan every 2 weeks. And you know, for TTTS, it occurs from the 16 to 26 weeks. After 26 weeks, no TTTS. But for TAP, it can occur through the second to the third trimester, from 16 weeks to 35 weeks, not after 26 weeks like before. Now, the studies show that the TAP can occur from the 16 to 35 weeks. So every time we have to measure the MCI-PSV, and when we say that the discordant in the MCI-PSV, we can have to for better the diagnosis and for better the management. So I think for the monochorionic selective monochorionic complication, now we have more and more evidence for the treatment, for the diagnosis, but some complications still very difficult to have clearly for the evidence about the optimal treatment.
Thank you, Dr. Nguyen. So we have come to the end of our webinar. I would like to introduce the next webinar, Slow Flow HD for the examination of endometrial receptivity and implantation in assisted reproductions, presented by Professor Laurel from Department of OB and GYN, Eastern Virginia Medical School in USA. So this webinar will happen in next week, Wednesday, 18 May. So, and once again, thank you everyone. We appreciate you being here. And thanks again for joining us today. We will see you next time soon. Thank you, Dr. Nguyen and everyone.
Thank you, Ji. Thank you, everyone. Have a nice weekend. Bye-bye. See you next time.
Thank you very much, Dr. Nguyen, for your passionate lecture again. We hope to have you again for another great session in the near future.
Sure.
Thank you very much again.
Bye-bye.
Bye-bye.
Good night. Bye-bye.